Good morning, everyone, and we're delighted to welcome you to our second DMD Care UK webinar. Today's webinar is about steroid stress dosing. Now, I'm going to be honest and say steroid stress dosing is something that I've, as a parent, really never understood. So I'm really looking forward to today's webinar and learning from Dr. Jarod Wong, who is the Clinical Senior Lecturer at the University of Glasgow, and also leads the Bone and Endocrine Working Group for DMD Care, and Mr. Dan Purton, who is the Paediatric Endocrine Nurse Specialist at the Royal Hospital for Children in Glasgow. So during the webinar, if you've got any questions, please type them in the Q&A box, or at the end of the presentation, if you want to click the raise hand button, we can open up the lines and let you ask questions. We are recording this webinar, so it will be available to view after. So I'm now going to hand over to Kathy Turner, who is the DMD Care UK project manager. Kathy is going to give you a brief introduction to the project before handing over to Jarod. Thank you.
Thanks, Alex. So hello, I'm Kathy Turner, as Alex said. I am the DMD Care UK project manager, and I'm based at Newcastle University in the team with Professor Volker Straub and Dr. Michaela Guglieri. So within the DMD Care UK project, we've set up a number of working groups across the different areas of the standard of care. For example, we have working groups in cardiac, physio, psychosocial care. And one of the tasks for each of these working groups will be in making UK recommendations based on the internationally agreed standards. So today, we're joining the Bone and Endocrine Working Group, and this has been established for the longest and has made fantastic progress. You can see their clinical recommendations and their patient information, as well as being able to order a steroid alert wristband that's come out of this working group as well on the project website, and that'll be put up at the end of this webinar. So now I'm delighted to hand over to Dr. Jarod Wong, who's the chair and the lead of this Bone and Endocrine Working Group, and has been a huge driving force behind the progress that's been made already. So as Alex has said, Dr. Wong is based in Glasgow. He's a consultant paediatric endocrinologist, and he specialises in bone development and endocrinology for Duchenne muscular dystrophy. So thank you very much, and I'll hand over to Jarod.
Good morning, everyone, and thank you, Kathy, for the introduction. As we know, today's webinar is on steroid stress dosing for emergency or adrenal insufficiency as a result of long-term steroids. And as Alex said, the whole issue of steroid stress dosing does tend to stress parents quite a lot. And I'm hoping by the end of this webinar, you will be slightly less stressed and have a better idea of how to approach the situation. Adrenal insufficiency and the need for steroid stress dosing is something that we know and occurs in all children or all adults who take long-term steroids. It perhaps hasn't been as well addressed in the DMD standards of care up to much more recently in the updated international standards of care, and very nicely supported by documents developed by our friends from across the pond at the parent project at Muscular Dystrophy, PPND, as part of the PJ Nikolov steroid protocol. We have adopted the principles laid out in the very excellent PJ Nikolov protocol and the international standards of care to see how this can be implemented in the UK in a fashion that works for the NHS. So before I go on and talk to you about adrenal insufficiency and the issue of steroid stress dosing, I'd like you all to do a little bit of work so that we can see where you are in terms of understanding the situation. It gives you also some scenarios which we often ask questions that make things a little bit more easy to understand. So there'll be 5 situations you will have to vote. We will see where you vote, and we will also test you again at the end of it just to see if you've got a better understanding. So let's look at first patient. So this first boy is John, who's 10 and he has DMD and he's been taking daily prednisolone for many years now. It looks like John has developed gastroenteritis as he developed loose stools in the evening. And the next morning he woke up and he actually vomited 3 times, about an hour after he took his usual dose of prednisolone. He has very poor color, and in fact, actually, that cartoon looks like he's quite green and doesn't really look very well at all. The 4 options of what you should do, and I want all of you here to vote. It doesn't matter, you need to just vote one answer. Would you give him another dose of prednisolone, given that he's already had his prednisolone? Would you just give him some fluids and just let him sleep it off? Would you ring an ambulance and give an injection of hydrocortisone? Or you say, I am really not sure what to do. So can we have the answer? So please all vote either 1, 2, 3, or 4. Don't think too much, just what you think you should do or would do. Answer 1, 2, 3, or 4. I'll just give you a couple of seconds for everybody to vote, and we'll see what most people think. Right, hopefully you've had the opportunity to put in your answers. Shall we look at the percentage of answers? So looks like most of you just say fluids and another dose of prednisolone. Okay, let's move on to the next case. So the next slide, please. So we now have Peter, and Peter is a boy with DMD who's 6, is on daily Deflasco. He's probably started over 18 months. Peter was walking his dog and tripped and fell on concrete, and he is in absolute agony. And there looks like there's a large swelling on his left leg. And we know that weak bones, osteoporosis, and fracture is very common in boys with DMD on steroids. You worry like there might be a fracture, and he's certainly never been in such amount of pain. So what would you do? Would you just give him some painkillers and see how he is in the next couple of hours? Would you think that it's not quite right, I need to ring an ambulance and ask, either give an injection of hydrocortisone or ask the ambulance staff to give an injection of hydrocortisone because you're out in the park? Ring the neuromuscular team urgently, or just give him another dose of Deflasco when you get home? So shall we have the answers? Can everybody vote, please? So a boy who's fallen and has got a large swelling and the options are painkillers, ringing an ambulance, an injection, ring the neuromuscular team, or giving another dose of Deflasco. So please, everybody vote. I'll give you a couple of seconds so we can see what everybody thinks we should do. Okay, everybody had the opportunity to vote. So shall we look at the answers, please? So most of you think ring an ambulance and give injection. Some say ring the neuromuscular team. Okay, let's go on to the next boy. Daniel is 11, is on daily Deflasco. On doing his x-rays, which we know is now part of standards of care, the doctors have found that he has vertebral fractures. About a year ago, he also fractured his leg. And as most of you will know, that in this scenario, particularly when there's vertebral fractures, we would recommend starting on bisphosphonate infusions. And he had that the day before. In some boys with, who receive bisphosphonate infusions, much more severe reactions, especially with first dose, can be seen. And certainly Daniel woke up the next morning with a fever, feels very lousy, and actually looks very drowsy. And look at Daniel there, he just doesn't look very well at all, isn't it? So the options are, would you just give him paracetamol, or give him his favorite breakfast, or just give him his Deflasco, or actually you think, ring an ambulance and give an injection of hydrocortisone? So let's look at the answers and please vote again. So he's had bisphosphonate infusion, looks quite lousy, a bit drowsy. You want to give him paracetamol, give him his breakfast, just give him his Deflasco, or does he actually need an injection of hydrocortisone in this scenario? So just a couple of seconds again, and let's see what all of you do think. Okay, shall we look at the answers? So most of you say give Deflasco or inject, okay? So let's look at the next boy. So Robbie is 9, he's on 10 days off and 10 days off prednisolone. and looks like he's developed some kind of a viral illness with a bit of a sore throat, runny nose, and feels a bit hot. He does have a fever. He's now on his 10 days off of steroids. So he's not taking any steroids. Throat really looks quite sore, isn't it? So what would you do? Do you think he needs an injection of hydrocortisone? Do you think he needs paracetamol and just some extra fluids? Do you need to give him a stress dose steroid by mouth? Or do you need to take him to A&E? So let's have the answers, please. So either injection of hydrocortisone, paracetamol and fluids, stress dosing, or taking him to A&E. And what are your answers? Please vote, and we'll see what are the top 1 or 2 answers. Okay, let's look at the answers. So most of you say stress dose and some paracetamol. Okay, and the final one. I thought I couldn't do this without talking about COVID, and certainly this is a situation I've been asked at least a couple of times recently. Ewan is 13 and is on daily prednisolone. He tested positive for COVID, does have an irritating cough, but seems to be quite well, like most younger children with who have tested for COVID. Importantly, he's got no fever, so a bit of an irritating cough, but overall still quite well. So what should you do? 1, I am not sure. 2, take him to A&E. 3, it's COVID, he should have an injection of hydrocortisone. 4, give him his usual steroids. 5, give him a stress dose steroid by mouth. So let's look at the answers, and please vote a couple of seconds, and let's just see what you think. So not sure, taking him to A&E, injection, usual steroid, stress dosing. Ewan is COVID positive, other than a cough, just seems to be quite well. A couple of seconds, and let's see what the answers are. So usual steroids and stress dosing seems to be the general answers. Okay, so thank you very much for participating. This seems a little bit like school, and we'll go through them again, but hopefully you'll actually understand the principles of what to do in some of these scenarios, which might be much more helpful rather than talking about abstract things in a slide. Right, okay, next slide, please. So before I talk about the issue of adrenal insufficiency and stress dosing and adrenal crisis, I just need to talk through some basic biology or endocrinology to help through things. And please forgive me if some of you actually have heard some of this or do have some sort of understanding. So glands are different organs in the body which help control hormones or secrete hormones. And the gland that secretes steroid hormones or cortisol, which is the natural steroid hormone, is called the adrenal glands, which are 2 glands which sits on top of the kidney. And these are these blue looking things up on this cartoon. The control of the adrenal gland is by another gland, which is called the pituitary gland. And the pituitary gland is in fact actually what I call the master gland and the master regulator of pretty much lots and lots of hormones and different glands in the body. The pituitary gland makes a signal called ACTH, which you see in this cartoon, and it actually tells the adrenal glands to make cortisol, which, as I say, is a natural steroid hormone. So next slide, please. The adrenal glands makes a certain amount of a cortisol or natural steroid, which keeps us all well and helps us stay energetic and for daily bodily function. The cortisol hormone or steroid hormone is also called a stress hormone, and you'll come to understand why it's also called a stress hormone. Steroid medicines, all kinds of steroid medicines, and in the DMD context, prednisolone and Deflasco are in fact artificial forms of the steroid hormones which the adrenal glands produces. For it to work in DMD or in any other condition, the dose that we need to give is in fact in excess of 5 times or 6 times more than what the body will produce. And when such doses of artificial steroid hormones or steroid medicines are taken for more than a month, This leads the body to think that, oh, there's just too much steroids in the system and I don't need to do my job. And what it does is that it actually switches off the master regulator or the signal the pituitary gland produces, which is called ACTH. And as a result, the adrenal gland of the boy with DMD, or indeed any patient taking high dose steroids for a long time, stops making its own natural steroid hormones. Now, and this is why we have adrenal insufficiency in boys with DMD, not that there's anything wrong or abnormal about the pituitary or the adrenal gland itself. In endocrinology, we see patients with other reasons of adrenal insufficiency. So certainly in some people, there are rare conditions of some boys who are born without an adrenal gland, for instance. There can also be antibodies which attack the adrenal glands, for instance. And indeed, some children or adults may have things like cancers around the kidneys and the adrenal glands, and the adrenals have to be removed. People can also have adrenal insufficiency because there are problems with the pituitary gland, for instance. If no adrenal steroid hormones are produced, the person will feel very lethargic, the person could feel very unwell and not have any energy levels. But we know that that is not the case in a boy with DMD because whilst they may not be producing their own natural steroid hormones, there is abundance of the artificial forms of steroids, i.e. prednisolone or Deflasco, which is in excess of about 5-6 times of what the body will produce anyway. Other terminologies that you may hear to describe the situation, particularly in the DMD context, when you take lots of steroids, is adrenal suppression. I sometimes use the word sleepy adrenal glands. So you can see these words used interchangeably, but in fact, they mean the same thing. So in DMD, the artificial steroids is taken in such high doses that in fact, actually the body switches off its own natural production of steroids. So on a day-to-day function, this is absolutely fine. Next slide, please. In normal people, people who do not take steroids or have any problems with the pituitary or the adrenal glands with minor stress, for instance, with a viral illness, with a fever, the adrenal glands mounts a response and produces 2 or 3 times much more of the natural steroid hormone to be able to cope with that stress or the stress of the infection. With a much more major stress, for instance, if somebody has got a much more severe illness like sepsis or meningitis, or at the time of operation, the adrenal gland will need to produce at least 5 times more, and sometimes maybe even 8 to 10 times more of the natural steroid hormones or cortisol to cope with the more severe stress. So in actual fact, as I already said, the prescribed dose of prednisolone and Deflasco in DMD, especially for ambulatory boys, is at least about 5 times more of the production of natural steroid hormone or cortisol, and sometimes even more. So the dose itself is sufficient to cope with stress of at least minor stress. In some boys with DMD who are in the non-ambulatory phase of adults, the dose may be reduced and it may be closer to twice as much. So message is that the dose that boys with DMD who are ambulatory is at least as much as what's needed to cope with minor or maybe even moderate to major stress. But there are some issues about artificial forms of steroids like prednisolone and Deflasco, and I'll talk through to in the next slide. So next slide, please. So in the natural situation during times of acute illness, the body knows how to make sufficient steroid hormones to last over a 24-hour period. So if somebody's not very well for a couple of days, the steroid hormones generally stays on the higher ranges over the 24-hour period. However, when we take artificial forms of steroids for prednisolone, for instance, it doesn't completely last 24 hours when we do blood tests to see how high the cortisol hormones are. For instance, in prednisolone, it probably only lasts about anything between 16 to 20 hours. And therefore, there is a concern, even if the dose itself is sufficient, but just taking it once a day might not be sufficient. There's even less information on Deflasco, and we think that maybe Deflasco might last in the bloodstream for a relatively shorter period of time. So therefore, in mild illness, just to reiterate again, the dose of steroid that you take from prednisolone and Deflasco should be sufficient to cope with stress, but taking it once a day might not be sufficient, more so perhaps for Deflasco, but potentially for prednisolone as well. So next slide. But the main thing that we all need to be worried about or concerned about is with situations with major stresses. And some of these have actually been addressed in the clinical scenarios earlier. So if a child has got a severe illness, and especially a vomiting illness where oral steroids cannot be tolerated, there needs to be a different way of giving steroids. So let's talk about the cartoon on the right first. So if the child has an operation for either spinal surgery or even other things like tonsillectomies and appendicectomy, it is critical that at the time of surgery, we give extra steroids into the drip. And after an operation, if the child cannot take steroids orally, for instance, if there's bowel surgery or appendicectomy, often the surgeons might say that the child can't eat or drink for about a day or two, then steroids need to be given in a drip. There should be alerts in the hospital, in the system, for this to be noted, but as families, it's useful just to remind doctors, surgeon, anesthetists of this issue. But in some issues prior to presentation in your hospital, when the child is very unwell, for instance, very floppy, where we think there might be meningitis or sepsis, or in severe gastroenteritis, where there's quite a lot of vomiting, and also I've talked about the issue of a reaction to the first infusion of bisphosphonate, or when there looks like there's a very likely long bone fracture and the boy is in a lot of pain. In those instances, it would be advisable to give steroids in a different route, and that's generally through an intramuscular injection. So these are the situations where you need to look into giving an intramuscular injection. And next slide, please. And I think that should highlight in red the situations where we need to consider the use of an intramuscular injection. And next slide, please. And some of you will have been issued with the hydrocortisone pack or hydrocortisone vials to be used at home for emergency. And this is now standards of care. Some centers might train you to administer the intramuscular injections, or you might actually be told to inform paramedic or medical staff of the need for extra steroids or intramuscular injections. The DMD Care UK have also produced some nice steroid bracelet. Bring your card or bring your doctor's letter to alert the relevant people of this particular issue. So next slide, please. So in minor illness, as mentioned, the prescribed dose of steroid is sufficient to cope with minor stress. In non-ambulatory boys might not be sufficient, and therefore giving steroids once a day might not be sufficient to lead to increased level of steroid hormones to cope with this stress over a 24 hours period. So next slide, please. And what we've recommended as a UK plan, which some centers have already incorporated, is that with minor stress, i.e. an acute illness with fever, but the child's not drowsy, one option is just to take extra oral steroids on top of your usual Deflasco or prednisolone. And this is in the form of hydrocortisone, but not as the injections, but as oral 3 to 4 times a day. Our recipe also gives a recommendation of using prednisolone as stress dosing, given twice a day on top of usual steroids. But of course, some boys are already taking prednisolone. So if your son is already taking 20 milligrams daily of prednisolone, and the stress dosing that's needed to cope with minor stress is only 5 milligrams twice a day, your doctor may actually ask you to just take 10 milligrams of prednisolone twice a day, or some centers might just say it's easier for the family just to remember to take the same dose twice a day. So there's some variability, but I think it needs to work within the center and it needs to work within the patient as well. So this is the recipe for minor stress dosing, either some extra hydrocortisone a few times a day or prednisolone on top, or a splitting of prednisolone. We were unable to give recommendations of Deflasco with the working group because there was just very little research on Deflasco, but some doctors may have experience, are happy to recommend giving Deflasco 2 or 3 times a day, and that's fine as well. And remember, this is just as an absolute precaution because with mild illness, the dose itself should be sufficient to cope with stress. So next slide, please. So this is really just put up, but really, I hope you don't get focused on the absolute dose itself. But this is really just a highlight, particularly with the prednisolone column, to show that actually, if you look at weight and you look at actually the dose that's needed for stress dosing, it's very low. Most boys with Duchenne take much higher doses. So the dose is sufficient, but it's the principle of splitting to a couple of times a day that might be necessary. So these are recipes and doses that we've recommended. I am aware that there are some slight differences in dosing regimen from centers, but that's absolutely fine. It's just a principle that perhaps it needs a little bit more spread of steroids in mild illness. And next slide, please. I think, which is probably my last slide before I hand over. So firstly, so all boys with DMD on steroids should be considered to have adrenal insufficiency if taken for more than a month. The main issue is that we need to inform hospital clinicians of the need for extra steroids during acute illness and also prior to an operation. And during major stress, steroid stress dosing should be given as an injection, and I'll talk through some of those scenarios. And during minor stress, we now recommend some guidance on an oral stress dose regimen to avoid precautions, to avoid major problems. So I'll leave it here and I will let Dan take on to show you how to give a steroid injection.
Hi folks, sorry, not sure if everyone can see me or not. Oh, there I am. So, hi, nice to meet everyone. I'm Dan. I'm one of 2 endocrine nurse specialists based at the Children's Hospital in Glasgow. My camera seems to have jammed a bit. I'm not sure if you're getting it on the big picture. But I've been asked just to go through doing the injection and how we do it. So yeah, I had a couple of slides, so I'll maybe put up the first slide and quickly talk through that. Oh, there we go. God, this is a new one on me. I'm not used to doing this. So basically, the first thing is kind of when should I inject? And again, that kind of goes over a lot of stuff Jarod's just kind of talked about. Now, usually when I'm speaking to my patients, I'm talking about things that are considered a serious illness or a traumatic injury. So we talk about things like a suspected fracture or a suspected broken bone. These will usually put a lot of stress on you. Things like a significant head injury, a fall, someone's cracked their head, you know, they've got a bit of blood coming down, that kind of thing. A significant reaction to a medication, that could be any medication. But for us, a lot of the time we're thinking about our bisphosphonates, so our alendronate. And the other one we always talk about is a vomiting illness, a gastroenteritis, a winter vomiting bug, anything you'd like to call it that's going to cause you to have a considerable amount of vomiting or diarrhea. And we usually talk about that one because you're not going to absorb your hydrocortisone properly or your oral steroid properly. For me, when I'm talking to my patients, I'm usually talking about the idea that if you think you need to contact a healthcare professional rapidly or immediately, give your injection. Okay, the big thing for me that I highlight to everybody is you can't do any harm giving the emergency dose. You can't overdose on it, so just go ahead and give it. Okay, I'll take the next slide if that's all right. So I talk to all my patients about carrying an emergency kit, and I'm sure you guys have probably had the same talk. I carry mine like so, in a little Tupperware box. And the reason I do that is because I like it all to be together. So what do I have in it? I tend to have a small syringe. So that can be sort of 1 or 2 mils, okay? I have a filter needle or a filter straw, okay? The ampule for the hydrocortisone is usually glass. So we have a little filter to just get rid of any possible glass particles. And the last thing we need is a blue needle, okay? We need it deep enough to get into a muscle. So we usually go with the blue size as being the ideal, okay? Because we want to make sure we get into the muscle so that it's going into the right place. There are a couple of extras that I'll often talk to my patients about, and that is carrying their steroid management plan or having a copy of it, whether that be you get the plan and you take a photo and you have it on your phone, but usually I like to have it with the kit. So I give a paper copy so that the guys can just fold it up and put it in their kit. Other things that can be quite helpful that are kind of extras is the Scottish Paediatric Endocrine group have a card called a Making the Call card, which is a kind of pre-generated script if you need to phone an ambulance, and it just kind of helps you guide through talking to the ambulance controller about what's required. And that would tend to be the kind of things I'd be asking the guys to have handy as one single kit. And yeah, so that's my slide. So what I'll do is I'll quickly run through the injection and take you through that and how to do it. Now my big camera doesn't seem to be working, so I'm hoping you guys are all getting it. So, kit, handy, take it out the bag. Okay, now the first thing for me that I want to do is just prep my site. Now, ideally, I want to go into the thigh. Okay, reason for that, not a lot of blood vessels around there. It's a nice safe area. It's a big area, so it's good to get into. And we know we're not going to go somewhere we're not supposed to. I like a box 1 because I like the lid. The lid acts as a wee table for me, so I can bring my stuff out, place it on there, ready to go. Okay, now, if you're at home, not such a big deal. If you're out at Tesco's, you don't really want to be doing it on the ground. I know we're thinking it's not a big worry, but it does just help to have a wee something to put it on. So I've got my area prepped. I know it's clean. Had a bath this morning, so I'm going to open up first and foremost my syringe. Now I keep the packets because I think you can pop your stuff back in as you need to. And I just open up my filter needle. Never looks easy. Now they all just peel from the top. So my filter needle is red, bright red, and I just take the top off, and that's me, and I'm ready to go. So I can lay that down there. My vial, I don't know if you can all see that. I got a bigger one just to make it a bit easier. So you guys will have a 1 ml vial, but my vial has a small dot on it, just at the thing, and that tells me the weak spot. Okay, now a lot of people get really nervous about opening these, and I remember when I first started nursing, I used to get really nervous. But the key for me is, if you're worried about it, use your t-shirt. Thumb against the dot, crack it open, and that's it, open. Okay. If you don't have your t-shirt handy, a tissue, just wrap something over it. What you're wanting to do is just lever, not squeeze. Okay, I then take my needle, filter needle, and I go. And I'm going to draw up to 1 ml because that is the advised dose for this young man. Now, if I hold it up, pull back, all the air will rise to the top. And if I just hold it straight up, I can push back up. Personally, I probably wouldn't bother if I was out in the street squirting it into the thing. I'd just squirt it on the ground. But then I've got 1 ml. So that's me. I've got the solution in my syringe. I can put the top back on if I want, very carefully. Alternatively, I can just put it to the side. I'm then just going to open up my blue needle. Pop that on, take that off. Now this needle is what's called a safety needle. So what I tend to do is I always push that to the side. just so that I've got plenty of room here, because if I don't, that's going to get in my way. So just push that to the side like so, okay, and it just folds down. It's designed to fold down, top off. I'm then going to use a kind of darting motion. So I tend to hold like this. One thing I tend to say to people is don't hold the end, because if you're in a stressful situation and a little bit nervous, you're going to push that and deliver the hydrocortisone before you've actually got it into the muscle. So for me, I tend to say, like a dart, hold like that, into the leg, nice and steady, straight in. Now I go all the way down. Once I'm there, gently pushing in. Now I leave it for a few seconds, just because that's going into a muscle and it needs a wee bit of time just to settle in. Then I'm straight out. That's me now delivered the hydrocortisone. Now afterwards, safety needle just goes on a hard surface with the blue bit down and push down. And that's it now, locked and safe, okay, which means you can't hurt yourself with it. So that's me, that is me now delivered the hydrocortisone. I've got somebody phoning an ambulance and I'm going to come up to the hospital and see Dr. Wong. The one thing I also like about having a plastic kit, and I know this seems really daft after all that and the stressful situation, but one thing you don't want to leave lying about is all your needles and stuff. So I tend to put that all back in the kit, because that's going to come with me up to the hospital to get disposed of. And that's me feeling better, come back up to the hospital and be seen. Now I can run through it again, and I'll just do that quickly, just so that you've had a couple of times. I'm hoping everyone can see. Like I say, my big camera's stopped working, so I'm hoping everyone's seeing it okay. So again, I'm opening this up, out with my equipment and my vial. Open up my syringe, I'm opening up my filter needle. So this is how quickly we can do it. I'm going to snap open my vial, take this in there, roughly 1 ml, up to the roof, squirt it out, 1 ml, put the lid back on, blue injection needle, push to the side, top straight off, and I go. Boom. Done. And that's me giving my injection of hydrocortisone. So you can see once you've done it, I suppose it's easy for me, I do it all the time, but realistically when you're doing it, it's around 3-4 steps, and you just go very quickly. And that is the idea. Then I can pop this back up. Like I say, I've then got an ambulance on the way, because that's the other important bit. I've then got an ambulance on the way, and I say to all my patients, if you need to give this injection, you need to come and see me. Like Dr. Wong says, it will probably only last about 5-6 hours. So realistically, if we've got a vomiting illness or something, we want to get checked out and make sure we're okay. So I think that's me. I'm not sure who's coming next. I think it might be back to Jarod. Oh, Amy.
Yeah, thanks very much, Dan. So hopefully you guys have managed to see the steps of giving in injections. This does not replace training by your center. So please don't take this as an official training by your centers, but it's just to give you an idea of the steps which are needed for an injection. And as Dan said, highlighted, if you get to a point where you actually need to give an injection to a young boy with DMD on steroids, you should present to the hospital for review. Okay, so let's go through some of these cases again, and we'll get you to quickly give your response, and let's see if your answers have changed in any shape or form after hearing what we've said over the last sort of 15-20 minutes. So we've got case one, who's John, who's on daily prednisolone, who looks like he's got gastroenteritis. He's vomited 3 times in the morning after taking his prednisolone, and his color is very poor. Let's have the answers. So do you, please vote again, do you give him another dose of prednisolone prednisolone, some fluids, and just let him sleep it off, ring an ambulance and give an injection of hydrocortisone, or are you still not sure what to do? So a couple of seconds, please vote now, and let's see what your answers are this time. Just a few more seconds, so please vote. Okay, let's see what you say this time. Answers, please. So most of you, more of you are just seeing ring an ambulance and give an injection of hydrocortisone. So certainly the correct or the recommended advice is that if he has a vomiting illness and actually he's very unwell, the crucial bit is that he looks very unwell, you do need to actually give an injection of hydrocortisone or ring an ambulance and ask for it to be injected, just because he may actually not be absorbing. So don't forget, with loose stools, it's unclear how much he's actually absorbed as he's absorbing his steroids as well. So certainly vomiting and diarrhea illness, and unwell, poor color, he needs an injection of hydrocortisone and actually presenting to the hospital. Okay, so more of you are sort of getting the idea of getting correct. Now, there are some people, for instance, if you kind of think that actually he's just got loose stools, he still looks quite well, you might actually want to just give him another extra dose of prednisolone if it's just a one vomit and he doesn't have poor color. But the key is that he looks very unwell. Okay, next case. Yep, so this is what we said the right answer. Next case, so it's Peter, who looks like has got a fracture and is in absolute agony. So do you give him some painkillers? Do you ring an ambulance and give him an injection? Do you ring the neuromuscular team, or do you just give him another dose of Deflasco? So let's a couple of seconds for the answers. So please vote again. Okay, answers, please. So, right, okay, great. So more of you know that an injection of hydrocortisone, exactly. So sometimes boys with DMD have a bit of a fall and they don't look too bad, but this is like there's a bruising, there's a big lump, and there's a lot that makes you think that I think he's broken his bone and he's in absolute agony. You certainly want to ring an ambulance and give an injection of hydrocortisone, okay? So next case, please. You all could also ring the neuromuscular team, obviously, and you might want to do that. So this is a boy who has doesn't feel well with drowsiness and fever after first dose of bisphosphonate infusion. So answers the options, please. So would you give him paracetamol, give him his breakfast, his Deflasco, or injection, and ring an ambulance? So please vote a couple of seconds and let's just see what you think. Hurrah! Everybody thinks that recognize poor Daniel. He doesn't look very well at all, does he? So yes, in this scenario, you want to actually get him to the hospital and actually get an injection of hydrocortisone at home if possible. Case 4, I think. It's Robbie, who's in his 10 days on, 10 days off, and he's got a sore throat, runny nose, and a fever, but doesn't look too unwell. He's still currently on his 10 days off. And again, the answers: an injection, paracetamol and fluid, stress dosing, or taking him to A&E. Just a couple of seconds for, yep, answers, please. Yeah, so I think this wouldn't warrant an injection. Certainly, you need to be unwell. He still looks quite all right. He's got a fever, so remember, and viral illness with a fever, he needs a stress dose plan. And on the 10 days on, 10 days off, so regardless of whether you're on or off, you need your stress dose plan. So yes, the stress dose plan is appropriate, which requires either splitting his steroids or actually taking extra steroids or the hydrocortisone in that instance. If he's on his days off, you obviously would give him some paracetamol and extra fluids as well. So the last scenario is, I think, Ewan, who's COVID positive as well, has no fever. Answers, please, and let's see what we all think. Couple of more seconds. Okay, let's look at the answers. What do we think? Give him his usual steroids and actually stress dosing. I mean, actually, I think you guys are right on this scenario on both accounts. And this is one where if he's got no fever, his usual steroids might actually be fine. So I think this is certainly both this perfectly acceptable, and depending on what you've been informed, that's absolutely fine. So I think the key is that he's got some kind of an infection, but if there's no fever and he's quite well, your usual steroids might actually be okay. Okay, so I think that's the end of my cases. I can't remember what the next slide is. It might actually be questions. Oh, yeah, sorry. So there will be a steroid stress dosing survey. I know all of you receive lots of surveys from different sources, but it will be extremely helpful. This will be released online over the next couple of days for parent and caregivers on your experience of the stress dosing advice that you've been given by your neuromuscular center, whether there are any impact or changes as a result of COVID, especially at the start of COVID, and the type of education that you've received, because I think this could help us shape care and also provision of educational material based on your feedback. So please do respond to the survey when you see that online. Next slide. So I think we're questions, so perhaps I'll hand back to Emily, I think.
Yeah, I'll pick up. Thanks so much, Jarod. And I just wanted to thank you and Dan so much. That was a really informative and useful presentation. I love the use of your polling, and I think the before and after answers definitely revealed that we've all learned a huge amount, and it's really going to stick in our minds. So thank you so much. And we've got about 10 minutes for questions, which is great because we do have quite a few. So the first one from Karen, why do different centres of care not issue the intramuscular injection emergency kit and some do? For instance, Newcastle has only advised on oral hydrocortisone.
So I can take that, Emily. I think like I say, I think there has been gradual recognition of the importance of this issue. And I think the 2018 standards of care and the PG Nichols have highlighted. So I think it's just a matter of gradually implementing it. And I think that's the whole issue with lots of aspects of standards of care and also the purpose of this project. So I think our sort of recommendations have been reviewed by all in the different North Star centres, and I think in due time this will come, so it will take time.
So there will be one set of guidance across every site.
Yeah. So I think the recommendations certainly, so the minutiae of the actual dosing and things like that and how we do it, especially with mild illnesses, don't get too stressed about that. I think the impact, the plan is that I think families should be issued a hydrocortisone kit, and this will happen with time, and some kind of a recognition of perhaps a oral stress dosing is needed with minor illness. So the dosing and the which drug we use might be slightly different depending on the center.
Okay, thanks, Jarod. A question from Alex. If you're not trained to administer the stress dose injection, what impact would there be if the ambulance was delayed in responding? So I think he means how long after an incident should the injection be given?
It's a good question, but sometimes quite difficult to be absolutely clear as well. So one thing that I perhaps haven't addressed and I can address here is that in adrenal insufficiency, the thing that you want to prevent is this issue called adrenal crisis, which some of you have heard about. In adrenal crisis, the child or the adult could become very unwell. You can drop your blood pressure, you can drop your blood sugar level. In extreme cases, people can be so sick they end up in ITU. And adrenal crisis is rare anyway, and in rare poor consequences of adrenal crisis is that you can become so sick you end up in ITU. We want to avoid that. Now, usually in patients who tip over to adrenal crisis, is not just because the steroid was given a little bit late. It's usually a couple of factors. So it could be actually the steroids was given much later, and we're talking about several hours down the line, or even 12 hours down the line. And actually the illness was actually very severe. So, maybe very severe COVID, for instance, or very severe meningitis. So it's absolutely difficult to answer the question, is it how long? We want it to be given soon, and we're talking about within a couple of hours at least. But of course, if the child is very unwell, it may need to be given much more promptly. So I wouldn't like to give an absolute sort of, time to it. It really depends on the clinical situation.
Thanks, Jarod. I mean, my son, I think, you know, he had an awful fracture last year in the park, and we didn't have his stress dose injection kit with us. Well, we didn't have one at the time because it was pre-COVID, actually. And the ambulance took about an hour and 45 minutes to arrive. And then he got the stress dose about an hour after being admitted into hospital. So, and that seemed to be okay for him.
Yeah, exactly. That's it. Really just talk about the stress itself.
So it doesn't have to be immediate, but as close as you can to within a 2-hour window would be ideal. Brilliant, thank you. Okay, a question from Sandra. What about boys who are taking high dose prednisolone 10 days on, 10 days off? If they become unwell when off the treatment, do they need extra steroid cover? Can that be prednisolone or hydrocortisone, usual dose or stress dose?
So I think I may have talked about it in the last bit of the question. So yeah, so I suppose if you're on the off days, you can either take the usual steroids, but I think the recommendation is perhaps splitting is better. So if your center recommends hydrocortisone, that's fine, or actually taking prednisolone twice a day, that's absolutely fine as well. Ooh.
Sorry, I was on mute. Another question from Sandra. Do you recommend to use glucogel as well as hydrocortisone injection?
The glucogel is recommended in some centres, and certainly we've not been as explicit in the UK standards of care, and certainly not used in lots of centres. So glucogel is basically a sugary sort of a jelly-like thing, and in severe adrenal insufficiency, when you've got severe illness, your blood sugar level could drop, and perhaps your blood sugar levels need to be brought up. One concern is that there are, as you saw from the injections, quite a few steps in giving an injection already, and we think it's actually much better getting the steroid injection in, because that will bring the blood sugar level up anyway. And actually, sometimes in some of the situations where you actually need an injection, the person might be a little bit drowsy already, and to try to get somebody who's drowsy, a little bit vomity, glucogel may not be very nice. It may potentially just make things a little bit worse for that poor child who doesn't feel well. So it is recommended, but perhaps actually less important on the grand scale of things compared to the hydrocortisone injection. I would say get the hydrocortisone injections first if you're trained to do that.
Thanks, Jarod. And this leads us nicely onto our next question. I think this is one for Dan.
Yeah.
Rachel asks, is there a danger or a chance that you could inject through a vein in the thigh?
So yeah, I'm hoping you can hear me. One of the reasons we talk about the thigh is because there's less chance of that happening. You sometimes will get a spot of blood afterwards, just because there are thousands of capillaries there, and I always get it when I teach schools. When I used to teach schools things, it would happen. But yeah, I suppose there is some risk, but the idea is to go for that big muscle where it's less likely. So that's why the thigh is usually the best place to go. But yeah, Dr. Wong and I had spoken about this before, especially we were talking around the boys with DMD, because trying to get, if you're in a wheelchair and you're unable to weight bear and you're trying to get into a thigh, that might not be quite so easy. So you can go into, we talked about the shoulder, where you get your flu injection is a good spot. But realistically, with that needle, I find it very easy to go all the way down, but I always say try and get at least half the way down. But you shouldn't be going deep enough to go into any major vessels. If you are going into them, you're probably going out the other side, so it's very unlikely. So I would just say, no, don't panic too much on that front.
Okay, thanks, Dan. Question from Kath. I have a little bottle of powder as well as the water vial. How do I mix that powder into the water and then into the syringe?
That's really interesting. So yeah, there are two different types of hydrocortisone. There's the one that comes in the vial called the F-cortisol, and you also get another one which is usually called Solu-Cortef. Solu-Cortef is the one that we've just been asked about. So it's a powder. So what you have is a powder and a vial of water. So depending on whether you got the plastic vial of water or the glass vial is whether you'll need your filter needle or not. But realistically, what you're going to do is open up your syringe, put your filter needle on, open up your water vial, draw up the amount of water, so 1 ml of water, and put that into the Solucortef. Okay, so you're going to put that into the vial containing the powder. Now, what you're then going to do is just pick up the vial and just give it a gentle swirl. Okay, just give it a wee gentle swirl around for a few seconds till everything looks clear. And then you're basically going to just put your filter syringe or your needle all the way down and draw up the one vial, the 1 ml of the liquid. Okay, and that's you basically then at the same step as you would be with the demonstration I did there. You'd just be taking your filter needle off and popping your blue one on. So the biggest difference there is the F-cortisol vial is made up. So that hydrocortisone in the vial is pre-made, so it's all just ready to go. The one with the powder just needs a wee mix with some water, and then you're roughly at the same stage. Okay, I prefer the F-cortisol just because it takes out one less step, but there are sometimes supply issues, so you may find both. One thing that I've found quite helpful with some of my patients is that the University College London have an app called My Cortisol. Now, it's slightly different dosing, so what I would say is ignore the dosing on it. But what it does have is a demonstration video of those two types of different hydrocortisones. And what it is you have it on your phone. So if you got to a point where you needed to give the injection and thought, I can't remember, you can jump on and just watch the video to get your brain going.
Thanks very much, Dan. Pauline, so stress dosing is in addition to their usual dose, and if a young man is on Deflasco, do you stress dose with extra Deflasco or prednisolone?
Right, so thanks, Pauline. So if a young person's on Deflasco, certainly in our UK recommendations, you can use hydrocortisone or you can use prednisolone. Some doctors may actually be comfortable to ask you to split your Deflasco into 2 or 3 doses. So that's appropriate as well. So remember, the dose of Deflasco should be sufficient. It might be that actually just taking it once a day is not sufficient.
And I'm just going to follow up with another question from Pauline. If mildly ill, should we split his usual Deflasco dose over 2 doses, i.e. half morning, half evening, or give his usual dose in the morning and an extra dose at night? And then an extra question from her, can we inject through clothing? Because if a young man is in his wheelchair, is it possible to lower clothing, or is it better to inject into the shoulder? So Jarod, if you could answer the first part, and Dan the second part. And we've only got a minute and a half left.
Yeah, so I think you need to talk to your doctor. So I think we've not been able to give a UK recommendation, but your doctor might be able to advise you on how you want to split the Deflasco. Dan, for clothing, quickly, I suppose.
Sorry, what was it? Someone quickly tell me the question.
Can you inject through clothing if a young man's in a wheelchair? It isn't possible to lower clothing, or can you inject into the shoulder?
So what I would say, personally, I would say go for the shoulder. It's easier to get into. You have your, if you're having flu immunizations, that's where they do it. So there's a good muscle there. I prefer not to go through clothing. The chance is you could take through some of the threads and push them into the skin. So for me, I tend to say try not to do that. I would go for the shoulder before I'd go through clothing.
Okay, and one quick question from Andrew. Thanks for the great presentation. Can we assume these same strategies apply for girls who are manifesting carriers of DMD?
Yeah, absolutely. So it's an issue with anyone taking long-term steroids.
Okay, I think we're just about out of time now. The webinar is being recorded, so you can watch it back later. I'm just going to hand back to Alex to say goodbye and thank you.
Thank you so much, Jarod and Dan. That was absolutely fantastic. Just a quick reminder that we will upload this webinar onto dmdcareuk.org. You can also order our information leaflets on puberty and testosterone and adrenal insufficiency, as well as ordering the wristbands. So thank you so much for joining us today. I personally have found this really, really useful. Thank you.